In this video, we will be covering chronic venous insufficiency or postthrombotic syndrome. Venous insufficiency results from obstruction of the venous valves in the legs or a reflux of blood through the valves. Superficial and deep veins can be involved. Chronic venous insufficiency is a form of venous disease that occurs when veins in the legs are damaged. As a result, these veins can't manage blood flow as well as they should, and it is harder for blood in the legs to return to the heart. CVI causes blood to pool in the leg veins, leading to high pressure in those veins. Chronic venous insufficiency may be a residual effect of phlebitis or thrombosis, so it is also called a postphlebitic syndrome. Chronic venous insufficiency can happen due to damage in any of the leg veins. These include deep veins. Deep veins are large veins deep in the body that run through the muscle. It can happen in superficial veins, which are close to the skin surface. And it may happen to perforating veins also. Perforating veins connect the deep vein and the superficial vein. CVI may cause mild symptoms at first, but over time this condition may interfere with the quality of life and lead to serious complications. Chronic venous insufficiency versus postthrombotic syndrome. Both terms refer to the same problem of damage to leg veins. Postthrombotic syndrome is chronic venous insufficiency caused by deep vein thrombosis. Deep vein thrombosis is blood clot in a deep vein in the legs. Postthrombotic means after a blood clot, which is also called thrombus. After the blood clot is gone, it can leave scar tissue that damage the vein. About 20 to 50% of people who have had DVT develop postthrombotic syndrome, usually within 1 to 2 years. Chronic venous insufficiency slows down blood flow from the legs back to the heart. Without treatment, CVI raises the pressure in the leg veins so much the tiniest blood vessels burst. When this happens, the skin in that area take on a reddish brown color and can easily break open if bumped or scratched. These burst capillaries can cause tissue inflammation in that area, tissue damage, venous stasis ulcers. What causes chronic venous insufficiency? Chronic venous insufficiency happens when the valves in the leg veins don't work properly. The leg vein contains valves that help the blood flow in the correct direction, that is toward the heart. If a valve becomes damaged, it can't close properly. Gravity takes over and the blood struggles to flow upward toward the heart. It instead flows backward, a situation known as venous reflux. It results from chronic occlusion of the veins, destruction of the valves congenitally weak or absent valves, or weakness in the calf muscle pump of the lower extremity. It may also occur as a result of hereditary. So the causes of valve malfunction may be congenital, primary, or secondary. Congenital causes are malformation in the leg veins that are born with. For example, some people are born without valves in their leg veins. Primary causes are any changes to the leg veins that prevent them from working as they should. For example, the vein may get too wide, preventing its valve from closing all the way. Primary chronic venous insufficiency is a symptomatic presentation without a precipitating event due to congenital disabilities or changes in venous wall biochemistry. Secondary causes are other medical issues that damage the leg veins. Deep vein thrombosis is usually the culprit. The thrombus or blood clot leaves behind scar tissue that damages the valve. Secondary chronic venous insufficiency occurs in response to a DVT, which triggers an inflammatory response, subsequently injuring the vein wall. Irrespective of the specific etiology, chronic venous insufficiency promotes venous hypertension. The most common non-modifiable risk factors are female gender and non-thrombotic iliac vein obstruction, that is maternal syndrome. Modifiable risk factors include smoking, obesity, pregnancy, prolonged standing, DVT, and venous injury. Regardless of the cause, the persistently elevated venous hydrostatic pressure may result in lower extremity pain, edema, and venous microangiopathy. Now, we will see the pathophysiology of chronic venous insufficiency. The peripheral venous system serves as a blood reserve and a channel for returning blood to the heart. The patency of blood veins, valves, and muscle pumps is necessary to function the venous system properly. To return to the central circulation, blood must travel against gravity and other pressures in the upright position. The veins of the lower extremities are classified as superficial, deep, and perforated. The superficial venous system consists of great saphenous vein, small saphenous vein, and several accessory veins. Deep veins are made up of axial veins. Perforating veins transverse the facial layer, connecting superficially to deep veins. A number of one-way bicuspid valves throughout the deep and superficial veins allow blood to travel toward the heart while preventing it from returning to the feet. In the case of venous thrombosis, smaller vessels dilate because the main channel for returning blood from the leg to the heart is blocked by a thrombus. Chronic venous insufficiency pathophysiology is either due to reflux, that is backward flow, or obstruction of venous blood flow. Chronic venous insufficiency can develop from the protracted valvular incompetence of a superficial, deep, or perforating veins that connect them. Valves of diseased connecting veins, that is perforators, that serve to keep blood flowing from the superficial system into the deep system can no longer prevent backflow. Superficial incompetence is usually due to weakened or abnormally shaped valves or widened venous diameters, which prevents normal valve congruence. In most cases, the leaky valve is located near the termination of the greater saphenous vein into the common femoral vein. Deep vein dysfunction usually owes to the previous deep vein thrombosis, which results in inflammation, valve scarring and adhesion, and luminal narrowing. Perforating vein valvular failure allows higher pressure to enter the superficial venous system. The subsequent dilation prevents proper closure of the valve cusp in the superficial veins. Most patients will also have the disease in the superficial veins. Because the walls of veins are thinner and more elastic than the walls of arteries, they distend readily when venous pressure is consistently elevated. Resultant venous hypertension can occur whenever there has been a prolonged increase in venous pressure. In this state, leaflets of the venous valves are stretched and prevented from closing completely, causing a backflow or reflux of blood in the veins. In all cases, the result is chronic venous stasis and venous hypertension of the lower extremities, resulting in swelling and edema as well as superficial varicose veins. The resting venous pressure is a summation of the outflow obstruction, capillary inflow, valve function, and muscle pump function. The lower leg becomes discolored because of venous stasis, which leads to edema and pigmentation changes due to hemosiderin buildup in the skin, resulting in a brownish discoloration. Uncontrolled edema may lead to dermatitis and ulceration. Most commonly involved deep veins are the iliac and femoral veins. The saphenous vein is the most common superficial vein affected. What are the signs and symptoms of chronic venous insufficiency? Chronic venous insufficiency causes many symptoms in the legs and feet. The symptoms may get worse or the patient may notice new symptoms as the condition progresses. Patient will have achy or tired legs, burning, tingling or pins and needle sensation in the legs, full or heavy feelings in the legs, cramping in the legs at night, discolored skin that looks reddish brown. Patient may have edema in the lower legs and ankles, especially after standing a while or at the end of the day. Flaking or itching skin on the legs or feet, leathery looking skin on the legs may be present. Obstruction or poor calf muscle pumping in addition to valvular reflux must be present for the development of severe postthrombotic syndrome and stasis ulcers. Postthrombotic syndrome is characterized by chronic venous stasis resulting in chronic edema. The edema will be worse while legs are dependent, altered pigmentation, pain, stasis dermatitis. Severe edema in the lower leg can cause scar tissue to develop. This scar tissue traps fluid in the tissues. The calf may feel large and hard to the touch. When this happens, the skin is more vulnerable to persistent ulcers. Stasis ulcers develop as a result of the rupture of small skin veins and subsequent ulcerations. When these vessels rupture, red blood cells escape into surrounding tissues and then degenerate, leaving a brownish discoloration of the tissues called hemosiderin staining. The pigmentation and ulcerations usually occur in the lower part of the extremity. In the area of the medial malleolus of the ankle is the most common site. The skin become dry, cracks and itches. Subcutaneous tissues, fibrosis and atrophy may occur. If they are very painful, they may be infected. The risk of injury and infection of the extremities is increased. The patient may have varicose veins. Superficial veins may be dilated. The disorder is long-standing. It is very difficult to treat and often disabling. The patient may not have all of these issues at once. Instead, the patient may only have one or two. The signs and symptoms depend on how far the condition has progressed. The patient may notice the symptoms less in the morning and more in the evening. How is chronic venous insufficiency diagnosed? Chronic venous insufficiency is diagnosed through a physical exam and ultrasound imaging. During the physical exam, carefully examine the legs for clinical signs of chronic venous insufficiency like ulcers or changes in skin color. Perform a vascular ultrasound. This test creates an image of the veins. It shows which part of the veins are damaged. Rule out other medical conditions that could be causing the symptoms like MRI. Doppler plethysmography is a non-invasive screening that shows obstruction and valve incompetence. Now we will see the treatment. Best treatment is the prevention of phlebitis and constant use of compression if phlebitis has occurred. After this syndrome has developed, only palliative and symptomatic treatment is possible because the damage is irreversible. The goals of treatment are to help the blood flow better in the veins, help ulcers heal and limit their chances of coming back, improve the skin's appearance, reduce pain and swelling. Treatment for chronic venous insufficiency involves lifestyle changes and compression therapy. Measures that increase venous blood flow are anti-gravity activities such as elevating the leg and compression of the superficial veins with graduate compression stockings. If these measures aren't enough, a procedure or surgery is recommended. The best treatment depends on how far the condition has progressed and other medical conditions the patient has. Management of the patient with venous insufficiency is directed at reducing venous stasis and preventing ulcerations. Usually, lifestyle changes are the first method of treatment for CVI. These include leg elevation. Lifting the legs above the level of the heart can help reduce pressure in the leg veins. Patients should do this for 30 minutes or longer, at least 3 times per day. Elevating the legs decreases edema, promotes venous return, and provides symptomatic relief. The legs should be elevated frequently throughout the day. At night, the patient should sleep with the foot of the bed elevated about 15 cm. Prolonged sitting or standing in one position is detrimental. Walking should be encouraged. When sitting, the patient should avoid placing pressure on the popliteal spaces as occurs when crossing the legs or sitting with the legs dangling over the side of the bed. Constricting garments, especially socks that are too tight at the top or that leaves mark on the skin, should be avoided. Walking and other forms of exercise can help blood flow better in the leg veins. Each time patient takes a step, the calf muscle squeezes and helps the veins pump blood back up to the heart. This calf muscle pump is known as the second heart. It helps blood in the legs defy gravity and it is vital for the circulation. So, making the calf muscle stronger can help improve the blood flow. The foot and ankle flexing exercise is also recommended for patients. Extra weight can put pressure on the veins and damage the valves. Patients should maintain a healthy weight. Patients should work with the provider to come up with a healthy and manageable plan for achieving that weight. Compression therapy for treating CVI is recommended. Compression therapy helps ease swelling and discomfort in the legs. Compression of the legs with graduated compression stockings reduces the pooling of the venous blood, enhances venous return to the heart. Each stocking should fit so that pressure is greater at the foot and ankle and then gradually declines to a lesser pressure at the knee or groin. If the top of the stocking is too tight or become twisted, a tourniquet effect is created which worsens venous pooling. Stockings should be applied after the legs have been elevated for a period when the amount of blood in the leg veins is at its lowest. There are many types of compression bandages and stockings. Some offer more compression than others. Very tight stockings require prescription. Some stockings are graduated, meaning they are tighter down by the ankles and less tight further up the leg. If stockings don't help, the provider may suggest intermittent pneumatic compression. IPC devices are inflatable sleeves patients wear on the legs that help blood flow through their veins. Antibiotics to clear skin infections or ulcers caused by CVI. These medications don't treat the underlying diseases. Anticoagulants or blood thinners to treat blood clots and prevent future blood clots from forming. Medicated wrap known as an Unna-boot. This wrap combines multilayer compression with a zinc oxide gel-based wound cover that forms a semi-rigid bandage. Non-surgical treatments for CVI include sclerotherapy. The provider injects a foam or liquid solution into the spiral veins or varicose vein. This causes the vein to collapse or disappear. Next procedure is endovenous thermal ablation. This technique targets large veins. It uses a laser or high-frequency radio waves to create intense heat. This heat closes up the diseased vein but leaves it in place so there is a minimal bleeding or bruising. Surgical treatments include ligation and stripping. These two procedures are often performed together. For vein ligation, the provider cuts and ties off the problem veins. Stripping is the surgical removal of larger veins through small incisions. Next procedure is micro-incision or ambulatory phlebectomy. This is a minimally invasive procedure. It targets varicose veins near the skin surfaces. The provider makes small incisions or needle punches over the veins. Then they use a phlebectomy hook to remove the problem veins. Next procedure is subfacial endoscopic perforator surgery. This is a minimally invasive procedure. It targets the perforating veins above the ankle. The provider uses a clip to block off damaged veins so blood doesn't flow through them. It helps heal ulcers and also helps prevent them from coming back. Next procedure is vein bypass. This is similar to heart bypass surgery, just in a different location. The provider takes part of a healthy vein from somewhere else in the body and uses it to reroute blood around the damaged vein. This method is used only in severe cases when no other treatment is effective. Now we will see the complications of chronic venous insufficiency. Venous ulceration is the most serious complication of chronic venous insufficiency and it can be associated with other conditions affecting the circulation of the lower extremities. Cellulitis or dermatitis may complicate the care of chronic venous insufficiency and venous ulcerations.